Check 1, 2. Okay, and test.
Yeah.
Thank you.
Vikan? Hello, hello. Yes. Okay. Can you guys hear me online?
Yes.
Okay, great. So, welcome to day 2. I hope you guys had a good nap, or rather sleep. How do you define the difference between a nap and sleep, I guess? We can debate that this evening, but I hope you had a good night's rest. Welcome back to day 2 of the second edition of the HMS BIDMC GI course. We are so excited. My coffee hasn't kicked in yet, so don't sound excited, but I'm very excited internally. So we have a full day. It's all GI, and then tomorrow morning and mid-morning and early afternoon, it's going to be liver. So you definitely don't want to miss it. There's some fantastic talks, and we'll have an open discussion with our hepatologist, Dr. Curry. I thought that yesterday's chat with Dr. Anand Krishnan was just awesome. It's so nice to actually hear what the clinicians want from us. And, talking about clinicians, I don't like using the word clinicians. We are clinicians too. So I should rephrase that and say what our colleagues want from us, and particularly hearing their pet peeves. So I certainly, I'm going to sort of press Dr. Curry to hear what his pet peeves on liver reports are. I guess one of his pet peeves is probably, this is non-specific. All right, so we're live on YouTube, ladies and gentlemen. As always, keep your questions coming. Questions come in the QA box and in the chat. If you have any issues with audio, visual, etc., please put that in a chat. You can always email. There was an email in your introductory packet. You can always email Aditya as well. So many ways of communicating us. Again, welcome, and let's get going. So I'm going to talk about pancreatic pathology, and I'm going to be very focused on what I'm going to say, right? I'm just going to cover 2 topics. One is, to me, what really troubled me as a junior attending, as a mid-career attending, now as a senior attending, is well-differentiated pancreatic adenocarcinoma, both on biopsies and on resection. And I'll do mostly biopsies, and my colleague Matt will do the biopsy thing, but we'll have a bit of overlap. And so we'll take questions at the end. And really the challenge is well-differentiated adenocarcinoma or chronic pancreatitis, right? And so take a look at this low power image. And I'm going to show you some images. This is the high power image. Yeah. Nobody's going to call this cancer, right? This looks a little more atypical, right? Particularly this sort of a profile that I shall go no further on. Notice there's a nerve sitting on the side here. It's sitting in isolation. That's good. We don't want nerves coming close to glands. Here's a bit of an islet. And the one thing I'll say about islets is particularly in chronic pancreatitis, particularly after, after neoadjuvant therapy, I really think they go insanely crazy and start proliferating as single cells and look very, very scary. All right, some more images. No one here is going to call this pancreatic adenocarcinoma. What if I tell you this is pancreatic adenocarcinoma? You're probably going to say, no way, it's not going to happen. I refuse to. I quit. My God, look at that. Bland, 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 bland. Just a cyst. It's sort of banal, bland. Anyone willing to call this carcinoma? Must be one brave soul out there. It actually is cancer. See that little critter there? It still looks bland. The reason I know this is, I love this. I learned this from Ralph Rubin, who always began his presentations on pancreatic cancer this way. He'll show you this really well-differentiated adenocarcinoma and tell you it's cancer because it's smack in the middle of a lymph node. Now, of course, you can have inclusions in lymph nodes, but I promise you this was widely infiltrative. And so this is adenocarcinoma. And that's what I want to do, is to spook you. And so I'm starting early in the day so you can recover through the day and still get a good night's sleep. And I think all of us are worried about missing a well-differentiated adenocarcinoma. And I mean, I've been doing this for 30 years. I still have trouble with it. I struggle. My colleagues here will know that I have a very low threshold for calling things adenocarcinoma. Anyone who comes to my office with a biopsy, I'll start with saying, this is adenocarcinoma. So everyone knows, we all know each other's thresholds, right? Some of us have low thresholds, some of us have high thresholds. I know my friend Matt here has a relatively high threshold, so I know precisely what he's going to call it. So that's exactly what I'm going to do. I'm going to try and help you distinguish between pancreatic adenocarcinoma and chronic pancreatitis, and for that matter, other forms of pancreatitis. So 3 rules to distinguish between pancreatic cancer and any form of benign pancreas or pancreatitis. The 3 rules are location, location, location. And so that's what we're going to focus on. So that's the theme of the first part of the talk. So we're going to look at 7 cardinal rules for making this distinction. Rule number 1, I'm going to trick you. Monica, would you mind just giving me, I forgot to get a cup of coffee. Just, thanks, sorry. I meant to get myself some coffee. I'm noticing I'm having some trouble getting off the ground here. So benign, guys, benign. It's a little fuzzy, I know. Is it fuzzy? Yeah, it is fuzzy. But, I could argue that this is very, very bland, right? But this is actually carcinoma, and that's the fundamental problem with pancreatic ductal adenocarcinoma. In fact, this is actually perineural invasion, and what I did was to hide that focus of perineural invasion. There it is. So another example of an extremely bland adenocarcinoma, and you can look at the monotony of the nuclei. The nuclear membranes are even there. The chromatin is not too bad. Oh, thank you. Ooh, nice. So perineural invasion. So rule number 1 is perineural invasion is pancreatic adenocarcinoma, right? You can take that to the bank. But for every rule, there is an exception, right? That's why we, as I told you last night or yesterday evening, that's why we get paid the big bucks. And the exception is, and we are seeing this more and more commonly these days, the exception is that you can have islets around nerves right there. See there? That's a nerve, and those are islets actually surrounding it, mimicking perineural invasion. And this is becoming more common today, particularly because many pancreatic resections follow neoadjuvant therapy. So neoadjuvant therapy wipes out a lot of the pancreas. The islets are always left behind, and then they crowd around the nerve. So there is one exception. There's one more exception to perineural invasion, and that's coming up later in the talk. So lots of islets, and it's right around, smack around that nerve. So this becomes particularly problematic if you're dealing with a frozen section slide, because if you're not aware those are islets, you'll call that a pancreatic adenocarcinoma and a positive margin. Okay, so there are more tips coming up. Ready for rule number 2? Rule number 2. There's a common theme here. So the question is this pancreatic adenocarcinoma? It's sort of blandish. It depends on where I am in the day. You know, before my coffee kicks in, I'm not willing to call this cancer. Once the coffee kicks in, I'll say, that looks a little atypical. But this is cancer. And that's rule number 2. Rule number 2 is a duct adjacent to an arterial channel is highly suspicious for carcinoma, regardless of the level of atypia in the duct. And you can take this to the bank or wherever you want to take this. So that duct is right next to that arterial channel, and therefore, by definition, that is cancer. I don't care how atypical this looks. And in retrospect, that does look a little atypical. So location is very helpful. These things are very helpful, particularly on a frozen section slide, helpful on permanent sections, but even helpful on biopsies. You'll be surprised how often you'll see an arterial channel on a biopsy with a duct right next to it. So the one thing I'd say about well-differentiated adenocarcinomas, we need all the help we can. So we need every one of these rules, because not every rule is going to work in every case. So in a case today, it's rule number 3 that works. Case tomorrow, rule number 7 that works. But let's test that rule and see if that actually works. Right. So I'm going to try and convince you that this is PANN. And PANN is pancreatic intraepithelial neoplasia. It's the pre-neoplastic thingy before pancreatic cancer. I'm sure I have a couple of these PANN lesions. Most PANN lesions don't progress at all. I hope mine don't progress. But take a look at this. I can convince you this is PANN. It always has a slightly papillary, tufted appearance, very round profile. To me, this looks really, really bland. Or can I convince you this is invasive carcinoma? It's probably cancer, right? But I may be tricking you again, so wait for it. Okay, this is case number 2, or example number 2, if you will. Can I convince you this is PANN? Or can I convince you this is pancreatic adenocarcinoma? So we have 2 lesions, 1, 2. One of them is PANN, and one of them is invasive carcinoma. This one is invasive carcinoma. And you're going to ask, how do I know? How do I know? How do I know? I know because that little duct right there is right next to an arterial channel. And therefore, regardless of the level of atypia, this focus is cancer just because of who it is associated with. You are associated by the friends you keep, right? So are pancreatic ducts. They are known by the friends they keep. And here it's right next to an arterial channel. So this is what is referred to as a PANN-like carcinoma. It's one variant of a very well-differentiated adenocarcinoma. They actually look like PANN, except when you look at this under low power, you'll see them randomly distributed. So the disorganized feature, which I haven't illustrated here. So these Panin-like adenocarcinomas actually tend to be, this is another example. In this particular case, the atypia is a little more, but I know it's this cancer because this is within in a venous structure, right? So there's a clear, smooth muscle coat around it. I've seen at least half a dozen examples of these Panin-like adenocarcinomas. There was a paper from the Hopkins group many years ago on Panin-like adenocarcinomas. They tend to look very bland, and they tend to be very angioinvasive as well. So it's one of those patterns that I don't think is widely recognized, but it's certainly something to be aware of. And there it is again, right? This was actually entering a lymph node. Here's the lymph node, and here is the Panin-like adenocarcinoma. This actually looks like high-grade Panin. We divide high Panin into low-grade and high-grade. In the old days, we used to call it Panin grade 1, 2, 3. So I just wanted to emphasize that these Panin-like invasive adenocarcinomas, in this case, we know it's cancer because it was right next to that arterial channel. But I do want to emphasize that this is a variant that is very deceptively benign. So just to reiterate, that was rule number 2. Ready for rule number 3? Want to call this cancer? Yeah, I can convince you. Burke here is nodding his head very vigorously. Thank you, Burke, for agreeing with me. Look at these nuclei, right? I can convince you that this is cancer. There's actually nuclear membrane irregularities. There is a lot of anisonucleosis, variation in size. There's even loss of polarity here. Remember, we talked about polarity yesterday. This is really scary looking. In fact, that's more scary looking than the first cancer I showed you, which was very, very bland. You want to think that through again, because this is benign. This is actually benign. In spite of all the atypia, this is benign. And the reason I know that is because I took that image from right there, right smack in the middle of a lobule, right? I also wanted to point out, look at these crazies here. These are all islets going insane. So the mantra, and this is, of course, cancer because it was perineal invasion. The mantra is anything that is lobular is generally benign, and you can take that to the bank. So the problem often occurs is when you go on very high power within lobules, particularly following neoadjuvant therapy, and sometimes outside the context of neoadjuvant therapy, when you look on very high power, you'll get yourself into trouble because there's very significant atypia. The moment you zoom up on low power, you'll see that lobular architecture. Lobular architecture, unless there is a compelling reason otherwise, is generally benign. So that was rule number 3, but we're going to actually, I'm going to give you a test, right? So this was a frozen section. I don't know whether I did this or this was in my Mass General days or a colleague shared this with me. This was the frozen, right? And you know, the pathologists have many nightmares. A pancreatic transection margin is very high up on that nightmare scenario list. And so for some reason, the pancreatic surgeons get very worked up when we make a mistake. A lot of surgeons get worked up, but I've noticed the pancreatic surgeons get a little more worked up than the others. The reason I'm stopping here is because I want you to spot the cancer. There's cancer on the slide. You'll see it in a minute. It's a decent frozen section. It's slightly on the thicker side. What I'm looking at when I'm looking at a frozen section is I'm looking for this lobular architecture, right? So much of this is lobular. But there is one abnormal duct here. There's one duct here, and that looks clearly benign. And generally, you don't see a lot of ducts in the interlobular stroma. But you guys see the evil character in here? It's right there, right? And so what I typically do when I'm looking at frozens is I'm looking at the whole slide, but I'm training my eyes to look away from the lobules. I'm not so interested in the lobules, which constitutes like 80% of the area. So That's how I speed up my frozen section interpretation. I'm looking within the lobules, and there's that gland here, and that is very atypical. You can see this loss of polarization. It's in the wrong location. You don't see very many ducts between the lobules. And here is what I refer to as an incomplete gland, right? So the gland is preserved on this end, but at this end, all of the cells have sort of fallen away, and that's helpful to me as well. So rule number four is this. This time, I'm not asking you if this is cancer. I'm asking you, why is this cancer? Again, a very bland adenocarcinoma. And this is cancer because of the random distribution of the ducts. And I think this sort of low power look is very, very helpful, right? If everything is organized in a lobular fashion, there's an occasional duct in the interlobular stroma, I can sleep happily at night. If you look at the ducts here, they're just all over the place. This randomness of the ducts is very helpful, particularly ducts infiltrating the fat. Now, there's a caveat to that. Just because you see a duct in a fat does not make it cancer. And that is because the older we get, the more that our BMI increases, the more fat you end up in the pancreas. And so occasionally you will have a duct within the fat in the pancreas. Remember, people with very high BMIs have an enormous amount of fat in the pancreas. And in fact, that's problematic for the surgeon. So don't forget this, the ducts in the fat are concerning, but do not equate to pancreatic cancer. All right, rule number 5. Intravascular tumor equals pancreatic cancer. And you're looking at me and probably saying, duh, huh? I know that already. You know? I don't have to go to medical school to know that if it's in the duct, if it's in a vessel, it's pancreatic cancer. But here's my comeback. I always have a comeback. Where's the vascular invasion here? You see it? Dr. Vyas and Matt know precisely where it is. It's hiding somewhere there. And the point I'm trying to make is it's hard to spot vascular invasion. It's actually right there. And that's referred to as the naked artery sign. And that's helpful in the context of not only pancreas, but outside the pancreas. In most organs, the arteries and the veins run together. So if you only see an arterial channel and don't see a venous channel, look around there. This works most of the time, but not always, because occasionally the veins just get obliterated and blown away. But watch for those naked arteries and look, particularly if you see a circumscribed aggregate of circumscribed aggregate of tumor. In this case, it isn't that circumscribed, but there is something that I can draw a circle around, right? So there's the artery, there's the vein, but I'm still not 100% sure that that's venous invasion. And that's where I know all of the residents know this. I speak a lot about this. This is perhaps your best friend. So there's that case. Here's the arterial channel. Here's the vein. And you got to, of course, on the elastic stain, you've got to identify tumor cells, because occasionally veins do get obliterated. In fact, they often do. And if they don't have tumor cells in there, obviously you can't call it vascular invasion. So the elastic stain is your best friend, and you can actually see these tumor cells in there. There's some caveats, particularly in the pancreas, to remember. Particularly around pancreatic ducts, there's a thick cuff of elastic fiber. So don't mistake that for a venous channel. So my rule of the thumb is I'll call it venous invasion only if there's an accompanying arterial channel. All right, so rule number 6, cytoplasm. I bet you've never heard of this rule before, or no one's really emphasized this. And I find this particularly helpful. Now, we're going from relatively hard criteria now to relatively soft criteria. So I will be the first to tell you that just because I see this pale cytoplasm, I'm not going to leap at a diagnosis of pancreatic adenocarcinoma, but I'm going to be suspicious. This, of course, is the so-called foamy variant of pancreatic adenocarcinoma, but I can guarantee you that most well-differentiated adenocarcinomas have abundant pale cytoplasm, sometimes but not always foamy. Most benign and reactive ducts have more eosinophilic or dense eosinophilic cytoplasm. And this, and I know Matt's going to be talking a lot more about this, this becomes particularly helpful in EUS-guided biopsies that come as fragments. So they tend to be very fragmented. You don't get whole chunks of tissue. But if you look at this, it almost looks like hypermucinous dysplasia. If you see that hypermucinous look, pale look, be very suspicious. I'll be the first to tell you that that's not diagnostic cancer, but watch for it. Right next door, there's actually this fragment. And if you look at this fragment, this is much more convincing this is cancer. In fact, now, which is something you don't often see, is you see irregular nuclear membranes. In fact, that looks like a little heart. You see it? Oh. So this is pancreatic adenocarcinoma, although I think some people will have trouble calling this pancreatic adenocarcinoma. But as my entire group knows, I have a very low threshold, particularly with Helen. Helen and I have thresholds that are oceans apart. So rule number 7, nuclear features. Now, nuclear features are actually hard features. Unfortunately, we can't really see them very well on a H&E slide. I think this is a feature, 4:1 nuclear variation within the same gland or within the same cluster of cells is a very helpful feature. This is an image that I took very, very long ago. This is a cytology image, and you can see the 4:1 variation in the same fragment. And this is diagnostic of pancreatic, adenocarcinoma in general, until proven otherwise. The other thing that's helpful is irregular nuclear membranes. Unfortunately, you can't see them very well on H&E sections, particularly hard to see on frozen sections. But on cytology preparations, of course, it's a lot easier. I don't know how many of you are aware. I'm a board-certified cytopathologist. So there's wearing my cytopathologist hat now for a minute. What I'm looking for is this deep indentation, these very deep clefts. A little bit of irregularity doesn't do it. That just could be preservation issues, but it's that really deep ones. There you go. So, I have a very high threshold for calling something nuclear membrane irregularities. But on an H&E, if you squint hard enough, you'll see some of these changes, but I'll be the first to confess, it's hard to see. There are times, if I'm asked to make a diagnosis of pan, not at the margin, but at frozen section, if somebody sends me a mass lesion, I will smear it because I think smears are a very helpful adjunct to make a diagnosis of pancreatic adenocarcinoma. You can't use that at the margin, obviously. All right, so let's try and put some of those rules into effect. So this was a pancreatic biopsy. There was a single gland here. How many of you are willing to call this cancer? One gland. One brave soul. You have good liability insurance, I hope. Because both of us need some legal coverage if we call this cancer on a one gland. One of the things I'll say about pancreatic adenocarcinoma is that when you see a mass lesion, particularly in a middle-aged or elderly person, the pretest probability that you're dealing with pancreatic cancer is so high, if you see what I mean, that even if you end up calling a benign duct cancer, very likely that patient has cancer elsewhere in any case. So that's perhaps one of the things that saves us at the end of the day. Anyway, so let's look at a higher power view. This actually was invasive adenocarcinoma, and I can't remember whether I called it or not. It really depends on whether it was a Monday or a Friday. But one of the reasons is, of course, there is some level of anisonucleosis, right? So when you actually start staring at it, there's one nucleus there, and there's a nucleus that is clearly 4 times that size within the same gland. So I'm okay with it. The other thing is the incomplete glands, these breaks in the glands. I find that particularly helpful. And then the cytoplasm, at least right there, there's that abundant pale cytoplasm, which is a soft sign, but it helps me. And And finally, the tumor is in adipose tissue, or at least adjacent to adipose tissue. That helps. And also, most importantly here, it's not part of a lobule, correct? So it's just an isolated duct sitting in the middle of nowhere. One of the questions that I'm often asked is, does the inflammation around it trouble me? And it doesn't, because reactive ducts look very different. So for a diagnosis of dysplasia, inflammation troubles me. For a diagnosis of cancer, it doesn't, because many cancers have a fairly robust inflammatory infiltrate. I love this one. Benign or malignant. You guys are going to have nightmares at night. Well, what's in favor of malignancy is that abundant pale cytoplasm, right? But look at the nuclei. That's not cancer. Those are extremely monotonous. Unfortunately, for you and me, this is cancer. And I know that, there is one soft feature, but I really know that the only reason I know that is this was it was a peritoneal biopsy, right? So there's no reason for these glands to be there. So when you see peritoneal biopsies, or you see sort of perihilar biopsies, or whatever biopsy you see, there are certain regions in the abdomen where you should not be seeing any glands. The other issue, of course, here, and this is where low power is very helpful, is that the glands are scattered randomly. So there's no organization, there's no lobular thing. So remember again the mantra, lobular good, non-lobular bad. If I had the entire audience here, I would have you chant that for the day. Lobular good, non-lobular bad. So, rules for this classroom. Respect for well-differentiated adenocarcinomas. Okay, I'm going to talk briefly about pancreatic cytology because I know Matt is going to be talking about it. But Matt, I hope it's okay because I think we'll just reinforce the same point. And I found I like wearing my cytopathology hat once in a while. I don't actively sign out cytopathology anymore. Maybe I should, right, Emily? Yeah. I'll think about it. I'll take it under consideration. So I love these images. Aren't they beautiful? I mean, they were so much better than the H&E image. So this is the so-called drunken honeycomb. And what does drunken honeycomb mean? That's a feature that I find very helpful and everyone finds helpful. But I want to tell you what I think it means. What it really means is that the cells at some part of the cluster are more crowded together, and in other parts of the cluster are more further apart, right? And that gives you the drunken honeycomb appearance. And I got ChatGPT to help me here. So this is the honeycomb pattern. That's a drunken honeycomb pattern, right? So spaced out and a little more chaotic in organization. That's a honeycomb pattern. That's a drunken honeycomb pattern. These are non-drunk bees. These are drunk bees. So the other thing is, of course, anisonucleosis. It should be at least 4:1, but in this case, it is only 2:1, so that's okay. There are other features, and these are classic features. I don't know whether anyone has read that monogram from John Frost. It's not very popular here. So if you're a cytopathologist and you haven't heard of John Frost from Hopkins, you're missing something. The Countway Library does have access to that book, so if you're ever interested, but that's the only copy I could find. It was written in the 60s. And essentially what it said, and these are sort of traditional cytopathology criteria, right? One of the things it says is if you divide a nucleus into 4 parts, you'll notice that the chromatin in each of the 4 quadrants looks somewhat different. And that's another feature of malignancy. And variable thickening of the nuclear membrane is another feature of malignancy. And here's a really lovely pancreatic adenocarcinoma. I got these from Jilene, and I'll tell you in a minute why I got these from Jilene, but irregular nuclear membranes in a drunken honeycomb pattern. Another thing that's very helpful, particularly in biliary brush specimens, is contrasting the benign that you will find with the malignant. So benign on the left, malignant on the right. We don't do very many air-dried smears. Parts in Europe that are very, very gung-ho on air-dried smears. But there is certainly anisonucleosis here, and even I could call this, but I'm not one of those who's very good at air-dried smears. Not infrequently, this is what we get. So for the most part, we see less cytology now. We see more core biopsies, and we tend to see these. We don't tend to see the entire structure of the tumor. Instead, we see these isolated clusters of cells. And again, notice you can start seeing the irregular nuclear membranes here and that very clear cytoplasm. So I also wanted to touch upon very briefly upon early invasion arising in an IPMN. The one thing I'd say is when you see IPMN, obviously you've got to put the whole cyst through. Occasionally I'll put, if the cysts are hard to define, I'll put most of the pancreas through as well for processing. And what you're trying to do is to find early invasion. Early invasion does not equate to good outcome. So you can have a very small focus of invasive carcinoma, a PT1A, that, or a PT, even a PT1B, right? There's a B? No. You know, so anything more than a 0.5 centimeter size. I hate staging. For some reason, I can never hold staging systems in my head. You know, there's some magnetic repulsion. The other thing, one of my pet peeves, is these nuances of the staging system, particularly when it's not defined in the staging system. What do? I just make up my own rules. So I'm happy to make up my own rules. I think the older you get, the more you're entitled to make up your own rules. Anyway, back to this, IPMN, that's a luscious papillary proliferation. And if you look at this, this is definitely high grade, right? I know we were quibbling about high grade on that appendix yesterday. Fortunately, those two gentlemen are no longer here, so I can call this high grade. But seriously, I mean, there are these micropapillary tufts. This is definitely a high-grade dysplasia. But what I wanted to show you is early invasion. And it's sort of a nice example. Those are the two foci of an early invasion. And you'll ask me, why is there early invasion? I think it's the shapes and the distribution of the glands. I am particularly worried about the angulated nature of these glands. The stroma isn't changing all that much, right? So desmoplasia is in the eye of the beholder, as I often say. So those are a few clusters of invasive glands. There's another one. So it's the shape of the gland, the angulation of the gland. So this was a small focus of invasion, and not infrequently, those clusters are very helpful. They're no longer forming glands, but they're forming irregular tiny clusters. That bothers me. That's invasion. A tumor with only this much invasion can metastasize and kill the patient, which is precisely why we need to identify these foci of invasion. But I want to give you a sense of what these early invasive adenocarcinomas could potentially look like. Here's another focus, and those two glands, I'm not so sure about this particular gland. This could be a tangential cut, but those two glands are cancer for two reasons. One is, notice the change in phenotype, right? They've gotten that more granular cytoplasm. They no longer have that apical mucinous sort of compartment. And two, it's the incomplete glands. This piece and this piece sort of broken apart. That gland has broken apart. That incomplete disrupted glands are, to me, very helpful. Okay, so the last part of my talk, I'm going to talk a little bit about autoimmune pancreatitis, because this is the number one mimic of pancreatic adenocarcinoma. For the most part, clinically, histologically, there isn't as much of an overlap. So if you talk about autoimmune pancreatitis, this is a disease of elderly patients, typically men, but we see a substantial number of women now. And what we discovered over the last 20 years is that it's actually two types of autoimmune pancreatitis. And if you want to take that 10,000-mile high view, there's type 1 autoimmune pancreatitis. It's associated with IgG4 cells and no neutrophils. Then there's type 2 autoimmune pancreatitis associated with neutrophils and few or no IgG4 positive plasma cells. And we could potentially stop there. And that's probably all you're going to remember from what I said, told you. You know, if you go back to talks, the question always is, how much do you actually remember from a talk, right? You'll probably remember my bow tie, but you won't remember anything I said. Well, I can't see my bow tie. I forget what I wore this morning. So let's look at type 1 autoimmune pancreatitis. I'm going to share this case with you because I really want you to get a sense of what these look like on resections. The first thing I will say is they look very lobular. So when you look at these on low power, what you should be looking for lobularity. Non-lobularity is no good. And between the lobules, you'll see a very expanded interlobular stroma. See that? And it's very cellular. It's packed with inflammatory cells. And in that interlobular stroma is where you will see the storiform fibrosis. So storiform fibrosis is like a cartwheel. There's the center of the cartwheel, and there's spokes of fibrosis going around. This is particularly helpful. In fact, on biopsies, this is all you might see. This is what I refer to as cellular fibrosis. And you'll see tons of plasma cells. It's a plasma cell-rich neoplasm. And you'll see these very plump fibroblasts or myofibroblasts. And it's that complement of cells that gives it cellularity. That, by the way, is an attempt to highlight an eosinophils. So you often see eosinophils. What's interesting is even though you have so much inflammation, the ducts are as happy and pretty as they want to look. And that looks like a rabbit. So look at that ductal epithelium. It is untouched in spite of the massive inflammation around. Oh, there's more, there's more. All right, so lots of eosinophils. I always feel good when I see eosinophils. Again, look at the lobular arrangement. At the periphery of the lesion, you'll often find these lymphoid aggregates. See them right there in the periphery? But the most characteristic feature probably is obliterative phlebitis. And that's where an elastic stain is again key. Because it's hard to find obliterated veins in a sea of inflammation, right? So we're looking, we're not finding. But I did do an elastic stain. There it is on the elastic stain, but I'm going to have to hunt it out on the H&E. And the rule of the thumb that works really nicely is a circumscribed aggregate of inflammatory cells adjacent to an artery is very suspicious of obliterative phlebitis. But often the only way you'll be able to define it definitively is an elastic stain. You look at the elastic stain, you must see inflammatory cells within the lumen. Acellular obliterated veins mean nothing. You've got to have the same level of inflammation as you do in the outside of the pancreas. So an elastic stain is again, your best friend. So let's talk about immunohistochemistry. Obviously, for type 1 autoimmune pancreatitis, it is the IgG4 stain. The IgG stain is less important. The one thing I want to say about the IgG4 stain is the cutoff is 50, but you generally see hundreds more. So 400, 500 per high power field. And I promise you, you don't have to count. It's that obvious. In many organs, the IgG4 to IgG ratio is important. But in the pancreas, it is less important. But nevertheless, most classic feature patients, untreated cases of type 1 autoimmune pancreatitis will have a ratio of almost 100%. Virtually every IgG4 cell will be positive for IgG. And you can see that this particular stain worked very nicely, but one of the problems with the IgG stain, of course, is that you tend to see a lot of background staining, and that's a challenge. Okay, let's talk about type 2 autoimmune pancreatitis. It looks different on low power. It generally looks less inflamed. The inflammation is more patchy, and the inflammation is generally surrounding the duct. So there's that peripancreatic, periductal inflammation. There you see a fair amount of atrophy, which you can see in both type 1 and type 2. But the characteristic feature, you can see the inflammation tends to not be all over the place. It's a little bit all over. There's a bit of sprinkling, but it's focused around the duct, and that's very, very typical. Another very classic feature is neutrophils within ducts, or the so-called, as my good friend Giuseppe Zamboni would call them, granulocytic epithelial lesions. And there's another very pretty granulocytic epithelial lesions. The ductal epithelium can be revved up. And in fact, in this particular case, a frozen section was done, and somebody was fearful that it was a very well-differentiated adenocarcinoma. Remember, the goal is not to resect them. The goal is to diagnose them, firstly, without biopsy. So many of our clinicians will diagnose type 1 autoimmune pancreatitis without a biopsy, but definitely to avoid a resection. So you can see some IgG4 positive cells in type 2 autoimmune pancreatitis. However, they tend to be very patchy. So occasionally you will find foci that are greater than 50 per high power field, which is the cutoff. I am not great in numbers. You know, I was instrumental in defining all those numbers for a diagnosis of IgG4-related disease. but I'm trying to move as far away from those guidelines as possible. Unfortunately, your past always tends to catch up with you. So I can't avoid it as much as I want to. All right, so now here's a test. Here's the working diagnosis. The working diagnosis was pancreatic adenocarcinoma. This is what EUS guide biopsies often look like. This was from Mass General. Here's a lot of fibrosis, so I'm not worried about that. Here's some, oh, look at that. So neutrophils and acini have the same meaning as neutrophils and ducts. So these are granulocytic epithelial lesions. So in theory, I should be quite happy that I'm dealing with type 2 autoimmune pancreatitis. But, you know, at the back of your mind, you're wondering, oh, could it be pancreatic adenocarcinoma? Could this be perilesional tissue? And then you see something like this. And I will highlight for you and scare you as much as I can. Here's a nerve, and here are epithelial cells around the nerve, right? So this is perineural invasion. This is pancreatic adenocarcinoma. Send the patient for surgery. Call your lawyer. All the above. Well, this is not perineural invasion. This is sometimes what happens with EUS guided biopsies. Remember, we spin them down, and just unfortunately, some of those glands would come and stick to the nerve. This is an artifact. This is not true perineural invasion. This is just there to hypnotize you and scare you. But you can see how hard a diagnosis this is. And this is the stuff that still, after all these years, still keeps me up at night. So last two slides, this is in your handout. This compares the histologic features of type 1 and type 2, and this compares the clinical features of type 1 and type 2. And I just wanted to finish off is a lot of those videos you saw are in this new book that Ranjan I, Dr. Bal, and Dr. Pinto have written. It's I don't know whether I'm allowed to do this, but it's a textbook of pancreatic pathology and cytopathology. And it has, you know, it's unique in the sense that it has all these videos built into the book and enormous number of infographics. So it's meant for the let's say the non-pancreatophile. So if you're a GI pathologist and don't have a deep interest in the pancreas, this is the book for you. So that's my sales pitch. It should be out, hopefully, definitely by the USCAP. So I'm happy to autograph it for you if you get hold of it. And I put it out there because I think it's sort of unique because it has a large number of videos. And so, you should be able to just click on the link and those videos will pop up. This isn't the final cover page. We are still wrestling about what the final cover page should look like. All right, I'll stop there. Matt, the floor is yours. So I'll introduce Matt. Matt Rosenbaum is let me start by saying he's the director of RFR information system. So he's the guy when Epic goes down, we all crowd around his room and he comes up with answers in a jiffy. But Matt is also an awesome cytopathologist. He's a GI pathologist. Did I miss? Oh, and he's a bone and soft tissue pathologist. So Matt and I have a lot in common. We're both cytopathologists, although I'm a non-practicing cytopathologist. We are both a bone and soft tissue pathologists, and we're both GI pathologists. And awesome, Matt was awesome at the microscope, but more importantly, he's one of the nicest guys in our group. And it turns out that Matt's wife and my wife work in the same practice in Boston, in Needham, actually. So we have even more in common. Come on over, Matt. Thank you for coming over.
The introduction.
Turn it to the YouTube video.
I'll turn it off for
Stop
there.
the share. Start the share.
Yeah. I'll stop share
Oh,
and do that.
is it the one from the?
This one, right?
Yes.
There's some-
No, I'm not as fancy as Vikram is in a lot of ways. So we will. I do not do sounds and animations as much, but luckily Vikram already covered a lot of my stuff. So
Sorry.
no, it's good. It actually works out because I kind of anticipated you cover certain things, so I deliberately left them a little bit light. So Hi, everyone. I'm Matt Rosenbaum. I do cytopathology, GI pathology, BST, and I'm also our LIS director. So probably would have been a lot of interest in a Epic Beaker lecture, but didn't really quite fit with the vibe what we're going for here today.